Thank you for attending the STN monthly webinar. This session is recorded that can be offered as on-demand CE for our members. Your lines are muted, but if you have any questions during today's presentation, please type them into the question queue box on your control panel. I will address any questions I am able to at the end of the presentation. STN is an accredited provider of continuing nursing education. To claim CE for this session, you must attend the entire session and complete the online evaluation of the presentation. If you are attending this session live, you will receive an email about 1 hour after the event with directions to complete the evaluation. Certificates will be emailed approximately 7 to 14 days after today's event. If you are viewing this session as an on-demand CE, you will be able to download your certificate after completing the quiz and evaluation. Today's session is interactive and will include several online polls. We hope that you gain great value from this session. Today's speaker is Jasmine Garces-King. Jasmine has been in the nursing profession for nearly 15 years, throughout which time she has worked with the trauma population. She obtained her RN diploma from Christ Hospital School of Nursing, St. Peter's College in 2001. She obtained her Bachelor's of Science in Nursing from Felician College and her Master's of Science in Nursing with a focus in acute critical care as an advanced practice nurse in 2006 and 2008 respectively. Most recently, she obtained her Doctorate of Nursing Practice through Chatham University in May, where her capstone focused on improving delirium outcomes for the critically ill trauma patient. In addition, she has been involved in grant funding delirium research and project management for delirium prevention and management within her institution. She has worked in several areas during the course of her career. Her main areas of expertise are in adult critical care units, neurosciences, neurosurgery, GI, transplant, general surgery, and trauma. She presently works as a trauma, surgery, critical care nurse practitioner and advanced practice nurse within the trauma division at New Jersey Trauma Center University Hospital. Please welcome Jasmine Garces-King. Hello, Jasmine, are you there?
I am. Hi, good afternoon, everyone. It's a pleasure and an honor to have this opportunity to speak with you all regarding a topic that I am very passionate about, and I think that all of us within trauma and critical care have the opportunity to make a significant difference in. So today we're going to talk about how to improve delirium outcomes through evidence-based practice in a surgical trauma intensive care unit. As Cody mentioned, this was the focus of my capstone for my doctoral work, and I'll be reviewing a little bit of what we did within my organization to improve outcomes. So, of course, we'll begin with the objectives. Number one is to describe delirium and its effect on national healthcare burden. Number two, we'll compare and contrast some assessment tools used to identify and assess delirium. Number three, to support the significance of interdisciplinary communication and collaboration. Again, as working in an academic medical center, it is of utmost priority. And number four, to apply delirium prevention and management strategies for the critically ill trauma patient. So we'll go over a little bit of an overview first as to what delirium is and some of the assessment tools, and then again towards the tail end of the presentation we'll discuss a little bit of the measures that were employed within my organization and some of those outcomes. And hopefully everyone will have something to take away to make a difference within their own organizations and our patients. So if we talk about delirium, by definition, if we look at it, it's truly just an acute decline in attention and cognition. If we look at it based on DSM-IV criteria, there's a couple of different things, which include there's a disturbance in consciousness and reduced attention, there's a change in cognition and perceptual disturbance, and the most important piece of delirium that should be understood is that it is an acute onset and fluctuating course.
We'll give everybody about 20 more seconds to fill in the poll, please. Okay, Jasmine, the question, order the subtypes of delirium from the most commonly to least commonly observed. 32% of attendees said hyperactive, hypoactive, mixed. 8% said hypoactive, hyperactive, mixed. 14% said hypoactive, mixed, hyperactive. And 46% said all are equally common.
As I expected, and this is what most of us, I think, are accustomed to, or what we think about, especially for those that are nurses and have worked at the bedside in an ICU. Most of us are very familiar with the patient that's the hyperactive patient, right? Very restless, trying to split their lines, trying to jump out of bed, when in fact, the most common subtype of delirium is the hypoactive form. Most of us don't really think about that patient as the first patient that pops into mind when we think about a delirious patient, because that's the patient that's normally calm, not as interactive, and isn't causing too much commotion, to be frankly honest, on the unit. But in fact, it is hypoactive is the most common, followed by hyperactive, and then followed by mixed states of delirium, where the patients vacillate back and forth between hypo, hyper, and so on and so forth, depending on where they are in their spectrum. When we talk about delirium, there's many risk factors that are to be considered. Some of them can be modifiable and some not so modifiable. Essentially, they're broken down, if you look at this simple graph here, onto a couple of different characteristics of things. The first one is patient characteristics, which, again, these are things that we really cannot change, correct, once the patient comes in. Age, alcohol, what their gender is, if they live single at home, whether they're smokers or non-smokers. In regards to age, the older the patient is, the more likely their chance of developing delirium. If they do have a history of substance abuse, such as with alcohol or smoking, that also increases chances. Gender, it does occur in males more than females, and then those that live single at home, it's deduced that this occurs because they have less social contacts. If we look at chronic pathology, again, not modifiable. Any patients that have predisposing cardiac, pulmonary, or history of cognitive impairments, again, these are all things that put patients at risk for developing delirium. Now, some of the things that are more modifiable that we can make a difference in, possibly, looking at their environments. Did they come in through an emergency room? Where did they come in through via transfer? Are they in isolation, again, with less contacts? If there's no clock in the room, if there's no visible daylight, if they have no visitors, are they in an open intensive care unit? Are the patients being restrained? In addition, their length of stay. Has the patient been febrile? What their injury severity scores are? Are they eating by mouth? Are they on several different perfusions or vasoactive agents? Are they on any psychoactive medications? And in addition, do they have any lines, tubes, catheters, and so on? And again, speaking of critical care, clearly most of our patients meet this criteria. When thinking about risk factors, Inoue and Ely really are two physicians I'm not sure if everyone is familiar with. Sharon Inoue has done a lot of groundbreaking work for delirium or delirium and the delirious patient, mostly in the medical side, in addition to outpatient type of settings. Wesley Ely out of Vanderbilt University, again, has done a significant amount of work in the critical care side, and specifically with trauma and surgery patient population. So between Inoue and Ely, there's been a lot of literature published over the past 15, 20 years or so that addresses some of these things. They have estimated that there are over 60 variables that at any time are associated with the development of delirium in the hospital setting. Sharon Inoue looked at 5 or more of the most commonly encountered factors in the hospital, which include use of a urinary catheter, physical restraints, poor nutrition, medication changes, and iatrogenic events, which is the second bullet that you see there. And again, unfortunately, most of our patients do meet this, even outside of the ICU setting. If patients have 3 or more of these 5 more commonly encountered factors, that puts them already at a 60% increased risk. So again, unfortunately, this does tell us that most of our patients are going to develop delirium at some point in their hospital course, especially when they're in the critical care unit. Ely and colleagues suggested that a patient in the ICU accumulates 10 or more of these factors of the total of 60, just by virtue of being admitted to the ICU. If we look at statistics, just to put things in a little bit more perspective for everyone, again, as I mentioned, in reviewing those risk factors, most of our patients are going to develop delirium at some point in their hospitalization. And it's about 65% of all total hospitalized, and the literature shows any range between 65 and upwards of 87% of all patients in the intensive care unit. Paper by Ely and his group back in 2008 looked at 100 patients in a surgical and trauma ICU. 70% of those patients had delirium, of which benzodiazepine was a very big factor. So that's something that's been evaluated since then. Another group, Van Rompuy et al. In 2009, looked at different risk factors, again, prior to hospitalization and during hospitalization, which correlate with some of those other discussions and some of those risk factors that I just showed you guys in that previous graph, including medications such as benzodiazepines, morphine, fentanyl, propofol. Again, many things that are similar with the type of care that's necessary when we're taking care of our patients in a critical care setting. If we look at healthcare cost alone, again, I think this is a perfect time to discuss this, considering the Affordable Care Act and how healthcare as a whole is truly changing in our country. Healthcare costs, the delirious patient, you can have 2 patients, same exact, to keep it simple for trauma, same exact mechanism of injury, same exact injuries. You add on the single diagnosis of delirium to patient B as opposed to patient A. That patient has a 2.5 times increased cost per day. On average, it's estimated that it's between $16,000 to $64,000 per patient. Again, just the addition of the diagnosis of delirium. And the national health care burden is between $38 to $152 billion per year.
We'll give everybody about 20 more seconds to answer the poll. Okay, the question, after hospital discharge, delirium is associated with 98% said care in long-term care facility, decreased functional status, and 2% said improved functional status at 6 months.
And you guys are right on target with that. That is completely accurate. You know, I say to people often when I'm speaking on this topic, when I first became an ICU nurse, sadly now I can say that my favorite patient at that time was paralyzed, intubated, and sedated for a couple of reasons, right? It was usually because these were the patients that were the sickest in the ICU, and I truly did enjoy taking care of very critically ill patients. Unfortunately, now all of the research has shown and all the literature has pointed to the significant sequelae that comes with these patients being intubated, sedated, paralyzed, all of those types of things on the long-term outcomes. It's not just something that's temporary for the little snapshot that we see as clinicians while they're in the intensive care unit. Therefore, when we're looking at morbidity and mortality, death, dementia, and long-term care institutionalization are all increased, as well as long-term outcomes, which show that residual cognitive impairment can still be seen upwards of 1 year after discharge. Delirium alone, again, is a single predictor of long-term cognitive impairment in survivors of patients with critical care illness. Ely, again, and his group back in 2010 put out a paper in Critical Care Medicine, and this was specifically with medical ICU patients. They looked at these patients that had been ventilator dependent, in the medical ICU, had developed delirium, and they did cognitive assessments on these patients at the 3-month and 12-month mark post-discharge. At the 3-month mark, 79% of these patients still had cognitive impairment. 62% of that total 79% were still classified as severe. At the 12-month mark, 71% of patients, again, still had cognitive impairment. About 50% of that subgroup were still classified as severe. So it is a very significant problem that we're seeing, which again contributes to the healthcare burden and to the total healthcare cost for us. So knowing all of this information, it's tremendously prudent that we have adequate assessment skills as clinicians, and that we understand that there are validated tools available to us in order to assess our patients on a daily basis. And we'll go into that a little bit more in detail. So one of the first tools is the CAM-ICU. Again, it's the confusion assessment method for the intensive care unit. This came out of the Vanderbilt group as well with Dr. Ely, and he kind of was the founder of this. The RASS is the Richmond Agitation Sedation Scale, and this is something that we need to use in order to make an assessment whether or not we can continue to assess for delirium, depending on the patient's mental status. The DOS is the Delirium Observation Sedation Scale. It's another validated tool. More often, this was a tool that's been used outside of intensive care units. And then we have the ICDSC, or the Intensive Care Delirium Screening Checklist, as another option. And we'll go over all of those. I'll show you guys a quick little preview of each of those in just a second. So this here is the Delirium Observation Screening Scale. This is just a snapshot here, but it's essentially something that you can use outside of an ICU setting, ideally, because it's a very quick kind of down and dirty checklist. It goes through numbers 1 through 13, and you can see some of the questions here. And then if the patient has 3 or more that are sometimes or always, those would be patients that would be considered delirium positive. The ICDSC, or the Intensive Care Delirium Screening Checklist, again, is another tabulated checklist that the staff can perform to take a look and see, based on number and objectivity, whether or not the patients are deemed to be delirious or not. It's a minimum score of 0 and a maximum score of 8. And for this tool, if they have a 0, it's considered a normal classification. If they have a 1 through a 3, it's a syndromal delirium, and a 4 through 8 is a guaranteed delirium positive for these patients. The RASS is the Richmond Agitation Sedation Scale, and if you take a quick look here, 0 should be what most of us are, alert and calm. And then it can go anywhere up to a +4 for those patients that are very combative, or a -5 for patients that are completely unarousable. In order to utilize most of these checklists, specifically the ICDSC and the CAM-ICU, which we'll talk about in a second, the patients really have to fall within a point on the RASS scale where they're able to be a bit interactive to continue to make your assessment using one of these tools.
We'll give everybody about 20 more seconds. Okay. The question, when assessing a patient's RASS, what is considered the baseline for comparison? 49% said pre-hospital RASS. 40% said RASS at time of arrival. 6% said RASS reported by a colleague. And the remaining 6% said RASS does not need to be evaluated.
So as I mentioned before, when using, again, specifically the ICDSC and the CAM-ICU, the patient does need to have a RASS assessment performed. And truly, if you look at Ely and his group and what their recommendations are, it should be a patient that has a RASS of no more than a -3. Because if they fall into a -4 or -5 category, these are patients that you're not going to be able to elicit a response on some of the questions that you're trying to get from the patients. So this just shows a quick little chart on the confusion assessment method for the ICU. So number one, if you look point by point, and these are all called features. So feature number one is an acute change or fluctuating course of mental status. Again, so what we should really be looking for is the patient's pre-hospital baseline. So if the patient was a GCS of 15, awake, alert, and otherwise a RASS score of 0, they get to our institution and now they are not, then that is a change in their baseline mental status. So do they have an acute change or fluctuating course? That right there, really should be a quick down and dirty yes or no answer, and then you have to realize, do they have a change in their RASS? And are they at a RASS level where they can actually be assessed? So again, anywhere no further than a -3, because -4 and -5, you won't be able to get any interaction with them. So feature number one is a yes, and then feature number two is a yes. You're looking for inattention. So there's a couple of different options. They've recommended using the Save a Heart acronym. So you have the patient squeeze your hand every time you say the letter A, and then depending on the number of errors they have, that will rule them in or out. If they only have 0 to 2 errors, then that makes them negative. But if they have greater than 2 errors, that makes them positive for that feature. So in order to be CAM positive, you need to have either features 1 and 2 plus either 3 or 4. So those are things that can be done, again, very easily with looking at their attention deficit and what the errors are. You can either do this inattention, as I mentioned, through the hand squeezing. In addition, there are some other things that can be used, such as pictures, that also have been recommended by Ely and his group. The other option to use is you can ask questions for feature number 4 for disorganized thinking, and the questions are, as you can see there, will a stone float on water? Are there fish in the sea? If they get, depending on the number of errors they get there, if there's greater than 1 error with these, then that makes them CAM-ICU positive. Most institutions utilize a RASS scale. So really that's the easiest way to go about it if your institution does use that. I'm going to attempt to play a video. Let's see if this works here. This is just going to go over a brief overview so that you can actually see what the RASS, or excuse me, the CAM assessment looks like.
Jasmine, the audio doesn't appear to be working. Could you send me the link and I'll send the video out to everybody after the webinar? I'm sure it has to do with the fact that you have a headset in and the volume's probably coming out of your headset and not through the speakers.
Oh, I'm sorry to hear that. Okay, it's not a problem. The link should be, again, they should be able to access the link straight through the PowerPoint, if that just gets typed into the browser.
Yes, all attendees, the PowerPoints are actually on the handout section of the webinar, so you can access that now.
So the purpose of the video really was to just provide an overview to actually see an assessment being performed. That was actually being done by Brenda Punn, who's a nurse practitioner as well, who's done a lot of the work with Dr. Ely out of Vanderbilt. It really shows, if you guys take a look at it later, it really shows the entirety of all of the single features to be addressed when performing the assessment, just for completion's sake. The true delirium assessment, if you're using the CAM-ICU, should take no more than between 60 to 90 seconds on average, depending on which features it is that you're using. So knowing all of this information, really what can we do as clinicians, and how can we try to prevent delirium? The most important thing, first and foremost, is assessment and identification. Other things we can look at are sedation protocols, sleep quantity and quality, light therapy, evaluation of the patient's medications, as I mentioned, benzodiazepines, different types of narcotics, significantly increase our patients' risk of delirium. In addition, other very holistic approaches that we can take are for music therapy, reorienting the patient, massage therapy, family education and involvement, and what I think is first and foremost is really healthcare provider education. And we'll talk about these a little bit more when I review the protocol that we implemented in my organization. So we decided to take a both pharmacologic and non-pharmacologic approach to treatment for these patients. So we did implement a new protocol from a pharmacologic standpoint. And all of the non-pharmacologic things that we utilized, again, were all of those holistic approaches that most of us that are nurses really do recall way back in our preliminary education in nursing school, such as the importance of sleep therapy, music therapy, again, massage, education, 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 and some more education for both the staff and the family. From a nursing standpoint, nursing-specific roles that can be utilized really are for assessment and identification. Although even for those of us that have been clinicians for many years, unfortunately, the literature has proven that delirium remains under-recognized or unrecognized in 66 to 85% of patients. So it's really important for us to continue to always be patient advocates as we are an integral part of the healthcare team. When my institution started doing our program, it was way back just in about 2011. And, you know, sometimes you're just late to the party or right on time, actually. At the same time that we had started our protocol, the American Association of Critical Care Nurses also put out a practice alert that discussed ensuring a couple of different things for delirium prevention and management. One of which was to ensure that delirium assessments were occurring at a minimum of once per shift for all critically ill patients, utilizing a validated tool. They did recommend using either the CAM-ICU or the ICDSC, as we discussed. Besides that, they asked, of course, that we should, besides just performing these assessments, that we should document and communicate these assessments at least once per shift with the entire healthcare team, and this is really where interprofessional communication and collaboration are key. We should, they also recommended patients be evaluated for risk factors, including a review of medications, again, which we'll talk about a little bit more, and considering strategies to decrease usage of deliriogenic medications, such as benzodiazepines, to include titration strategies, such as sedation scales, having a targeted sedation protocol, and daily awakening trials, as well as consideration of other sedatives, which were non-benzodiazepines, such as Precedex or dexmedetomidine or propofol. In addition, incorporating early progressive mobility and exercise for all critically ill patients. We know that a patient that is in the ICU just even for one day that's bedbound begins to lose a significant amount of muscle mass. So really getting these patients up and moving as early as possible. In addition, to evaluate the patients for causes of delirium, including medications using the Think mnemonic, which we'll talk about in just a bit. They also really recommended the ABCDE, and now I have in parentheses F bundle. The A is for awakening, so again, daily awakening trials, daily spontaneous breathing trials. C is for coordination and choice of sedatives, so again, trying to stay away from the benzodiazepines if at all possible. D is for delirium detection, and that would be through one of our delirium assessment tools, such as the CAM-ICU. E is for early mobilization, and since the time of 2011 where they put out this practice alert, they've also now added the F for family engagement and empowerment, because it's very important for us to, again, also remember that the patient is the center of everything, and that their family and loved ones that are visiting and are going to be involved with these patients, especially for the long-term outcomes, as we discussed, that they're really engaged and empowered to be part of the team with our patients. In addition, since that time, the pain, agitation, and delirium guidelines were presented through the Society of Critical Care Medicine by Barr et al. In 2013, which again really addressed the importance of identifying ways to decrease our patients' pain, decrease exposure or experiences of agitation, and to try and prevent and manage delirium as much as possible, because we do know that, again, unfortunately, most of our patients are going to develop delirium at some point during their hospitalization. In looking at the family, again, education is key. You really want to try and have them assist with trying to prevent delirium as much as possible, understanding how to minimize it if it does occur, and empowering them to assist with care. Family, again, it's a very tumultuous time when, especially for the trauma population, where, you know, mom or dad or whoever the loved one is was perfectly fine in the morning. Now, unfortunately, they've been in a terrible motor vehicle crash, and these people's lives are being turned upside down, literally in a blink. So it's very important to try and empower them to assist in any way possible so that they also feel as if they're contributing. In looking at physician-specific roles, again, assessment and identification is all of our responsibility. Medication review, not just for the medications that the patient is on in the hospital, but also reviewing medications that they were on pre-hospital that may also be deliriogenic medications, and trying to eliminate those as much as possible, if appropriate. In our institution, we did also utilize a health educator, and this person essentially just helped with data collection, family education, and helped to coordinate the program as well. So we decided, again, as I mentioned back in 2011, we did not have a delirium prevention and management protocol, and we decided that we were going to look at our hospital-acquired delirium and come up with a prevention and treatment program. So we created an evidence-based practice model for the prevention and treatment of hospital-acquired delirium in older adults, and at that time we were looking at patients specifically greater than 50 years old that were admitted to our surgical intensive care unit. When we first started this program, we didn't even know what our incidence was of delirium. We knew it existed, but we didn't even have any data as to what the actual numbers looked like. We hypothesized that the incidence and duration of delirium would decrease after initiating a prevention and treatment protocol. So we really used a multifactorial approach, which focused on the main crux really was multidisciplinary provider and family education on delirium and some pharmacology. We increased our screening. At that time, we were using the CAM ICU, but we did have concern that maybe our staff A, wasn't really competent in how to use the CAM ICU, or B, if they were doing it, it wasn't always getting documented, and so on and so forth. And that, again, was with all providers, not just the nursing staff, both the resident staff and the attending physicians. We really felt it would be best to come up with both a pharmacologic and non-pharmacologic approach, again, based on previous work and some of the literature that was out there. Our non-pharmacologic approach really focused on sleep promotion, basic hand-foot massage, which we educated our nursing assistants or patient care technicians to provide, and music therapy. In addition, we worked closely with our physical therapist and occupational therapist to begin or to start the beginnings of a true early mobilization program, which was something that we had been trying to do for many years, but unfortunately it just all hadn't come together. So this really was our crux to get that done, as well as a pharmacologic treatment algorithm. From an educational standpoint, again, all of our staff in the surgical intensive care unit, and PCU is the progressive care unit here, which is our trauma step-down unit where our patients come after they're downgraded out of the ICU. We're educated really about all of the causes and how to detect delirium, negative effects, and some of the things that we've discussed previously. Families were educated via a health educator. We provided pamphlets for the families. We placed posters in the room, and just also made the families aware that, unfortunately, this is something that is very prevalent, and that it's very likely that their loved one may experience delirium during their hospital stay. But that we as clinicians were being proactive in trying to minimize and identify it as soon as possible. Sleep promotion, we wanted to limit the use of sleep-impairing medications, again, such as the benzodiazepines. We did have a quiet time only in our ICU, and that was really only occurring once a day. We decided to increase that to 2 90-minute quiet times. And in addition, we really wanted to educate the staff on the importance of really ensuring that those quiet times were adhered to, so that if at all possible, we were not performing procedures or personal care or those types of things during what should be quiet time for these patients. In addition, we utilize bright light therapy to promote more normal circadian rhythms, especially we have a couple of rooms in our ICUs that do not have windows. And also, as I mentioned, provided massage therapy and gentle music therapy. From a mobilization and range of motion standpoint, we incorporated, my hospital is affiliated with Rutgers University, so we used their School for Health-Related Professions and collaborated with their physical therapy instructors and had students to come into our ICU to expand our own therapist treatments. They really focused on reorientation, early mobilization, and education when possible, with, again, the staff and the family as well. From a pharmacologic standpoint, we looked at sedation. Again, we tried to limit the use of benzodiazepines. We used propofol as the preferred infusion, and we do use Precedex here as well at times. We tried to limit our continuous opioid infusions. We decreased other deliriogenic medications, such as H2 blockers, anticholinergics, things such as Reglan, and again, wanted to ensure that patients had appropriate pain management, especially for preemptive treatment for painful procedures, such as early mobilization. So this is just a brief overview, and you guys can take a look at this at length on your own time. But these are some of the things that we were looking at when trying to manage their delirium. If they have substance abuse, whether or not they were elderly, did they have a traumatic brain injury, does the patient have dementia, were they in a hyperactive versus hypoactive form of delirium, and this kind of was our triage or our algorithm that we used to make determinations as far as medications were concerned. And again, this just shows, and this was also something that we created as a pocket card for our resident staff as well, since they do tend to rotate, every 4 to 6 weeks or so. So it gave them different options, so at least they knew where to start and where to go with some of these medications and how to escalate them and up titrate or down titrate as appropriate. Trazodone is what we used here for sleep because, again, H2s and different other medications such as Benadryl can have some issues with causing or increase the risk of delirium, so we try to avoid that if possible. Our study design was a prospective pre- and post-intervention cohort study to evaluate the impact of our program on all critically ill adults. Our inclusion criteria included all older adults age greater than 50. They had to be admitted to the ICU for at least 24 hours. Exclusion criteria were those patients with dementia, severe traumatic brain injury, which would be a GCS of less than 8, if they were in police custody or if their delirium status was unobtainable for the entire SICU length of stay. And that would fall into one of two categories, which is either the nursing staff unfortunately didn't document the CAM ICU, or the patients fell into a RASS of -4 or -5, so we could not actually assess them. Outcome measures that we looked at were primary outcomes were for incidence of delirium, and then we wanted to look at delirium-free days. Secondary outcomes were their ICU length of stay, ventilator-free days, and we wanted to look at daily and cumulative doses of medications for pain, sedation, and agitation. In looking at our study, we started with an N of 274. Because of TBI or dementia, we excluded 100 patients. That brought us down to 174. We had a couple of patients where we could not get their delirium status, brought us down to an N of 123. There were 57 in the pre-intervention arm, which took place between March and June of 2012, and then 66 in the post-intervention arm between July and March of 2013. The data was analyzed into two groups. When we looked at the things overall, we were pretty much comparing apples to apples, as you can see here, between the pre- and post-intervention groups. And what we found was pretty interesting. Pre-intervention, our delirium incidence was about 47%, and we initially thought we were going to decrease our incidence by implementing this protocol, but the reverse actually happened, and it increased to 58%. Our thinking really is that the 58% probably really reflects more accurately what our actual true incidence is. We just were underestimating it or under-recognizing it before we implemented this protocol. Delirium-free days went from 24 to 27. Our ICU length of stay decreased from 9 days down to 6 days, and our ventilator-free days increased from 23 days to 26 days. So all positive things. The total amount of time that patients were classified as being in severe pain, and that would be a pain scale of greater than 6 out of a 10 pain scale, decreased. And interestingly, the total amount of opioids we gave them decreased. So we gave them better pain control with less total amounts of morphine in that time. And these here are just some graphs showing some of the same. where again our ventilator-free days, depending on which group of patients we were looking at, changed significantly. And some of our ICU length of stay also decreased by a total of 6 days, anywhere between 3 and 6 days. We also looked at benzodiazepine use. Pre-intervention, we were using benzos 85% of the time. Post-intervention, we were down to 63% of the time. Really with no change in our total number of self-extubations or anything like that, which is something that, of course, many people are always worried about. In summary, our program really significantly decreased the duration of delirium post-intervention, despite the fact that the overall incidence was unchanged and actually, as I mentioned, slightly higher. We did have shorter ICU length of stay. The patient spent less time in severe pain and required lower doses of opioid analgesics. For those that were delirium positive and received the intervention, they were less likely to be treated with benzodiazepines. And if we did give them benzos, we gave them lower mean daily doses of benzos when prescribed, and they also spent less time mechanically ventilated. So in conclusion, really, the evidence-based practice delirium prevention and management protocol that we implemented, which was, again, a multi-component approach with both pharmacologic and non-pharmacologic protocols, did not prevent delirium. However, it did successfully decrease the duration of delirium in all older adults that we admitted into our surgical intensive care units. I hope at the end, now that we're at the end of the session, that you all can take something that you can apply back in your own organizations and look at your own data, really, and see how we can improve outcomes for all of our patients. Truly, it was a very simple, cost-effective program, which led to improved pain and sedation outcomes. Patients spent much less time, as I mentioned, on the ventilator, and all patients spent less time in the surgical intensive care unit. And that concludes my portion. I'll be happy to take any questions at this time.
Thank you very much for your presentation. There are currently no questions, but we can wait a few minutes. Attendants, if you have questions, you can type them into the question queue on the side. And again, you can download the slideshow as a handout on the side of the webinar, and also you'll be receiving a certificate within a week or two. Just make sure you complete the evaluation in the post-webinar email you'll be receiving in an hour or so. And since we are not receiving any emails or questions, if you have any questions for Jasmine, you can send them to me at info@traumanurses.org, and I will forward them to her, and if we can get them answered. Thank you again for joining us today, and have a great afternoon.